So next speaker is Dr. Rischke about lateral approach at the lumbar spine.
Thank you for announcing. The lateral approach is some special indication. I wanted to speak about the high lumbar and thoracolumbar approach. Again, my disclosure. I'm very familiar with this lateral minimal invasive arthroscopy approach due to the injuries of the lumbar spine, the trauma injuries I'm used to perform since a lot of years. And this is published in 1997 by Volker Bühren and Rudolf Beise from the BG Clinic Murnau in Bavaria, where I spent some time in that clinic. And the problem is, which I have seen, are the burst fractures in TH1. For instance, this one I performed thoracic with a transthoracic approach endoscopically. And for another example is the burst gap fracture in L2. I performed in the same manner by an endoscopic transthoracic approach with a diaphragma splitting and replacement of the destroyed vertebra. That is the same approach I would like to recommend in the DDD of the upper lumbar spine and proximal adjacent level disease I will show you later on. And perhaps also in the DDD of the lower thoracic spine. So I would like to note what is the problem. The problem is the approach to the upper lumbar spine. This is the approach we can reach from anteriorly in the red line. We see the alternative is to go from lateral with blue in this blue line. And if I go to the middle of the lumbar spine, L3, 4, for instance, or L2, 3, I use often the anterior approach if it is possible. It is a slim patient, but in some cases, if there's a fat patient, for instance, I perform the lateral approach. And this is the problem we can see. We have the approach from anterolateral with the nerve branches which are laying near the foramen, and so we have only approach to the anterior lateral part of the disc. And as we can see here, for instance, the vertebra L1 is behind the left kidney, so that's a problem to remove the kidney from the retroperitoneum. And in L2-3, we can go also from anterior or anterior lateral. And as I perform the surgeries in the Da Vinci position by the anterior approach on the left side, I am standing in the side position in the case of the lateral approach. And this is a patient in extreme lateral position, but there's a problem with the device of the prosthesis and the inserter, so we have only 20 degrees for angulation. Oh, sorry. I should put here. So, and so I did an endoscopic assisted approach for the exposure of the lateral spine. And as it is not possible to introduce the prosthesis strong laterally, but more oblique, I would recommend the anterolateral position in 45 degrees. This is in downsize is the head and the feet are up. So, and this is me again. So in the model, I can explain what is the technical trick to insert the prosthesis if I have removed the disc. So we have to put the inserter very laterally and to insert the prosthesis, but then the prosthesis is tucked. So, and I have to put with the inserter step by step the prosthesis in the correct AP and lateral position. The advantage is that I can protect the anterior ligament, as you've seen here in the model. So I have only a window in the anterolateral part from the half of the circumferential anterior part of the annulus. And then in the model here you can see the prosthesis can be placed very correctly, but it is quite tricky. And this is the interoperative view on the diaphragmal split below, and the psoas muscle and the ventral part and the vessels are positioned in the upper part of this slide. And then I can open the disc and remove the disc from anterior lateral and can complete extrude and prepare it. And this is one example from a patient with a DDD in L2-3. And this is the position of the prosthesis afterwards, and also in the MRI on the right side you can see the correct position of the prosthesis in the axial view. This is another patient with a severe multi-level degenerative disc disease, and what I want to remark is that here the L1-2 level, and the disc is healthy in the beginning, and afterwards he has been fused in another hospital with a long distance fusion and positioned of some TLIF cages. And he came to me with these adjacent level disease in L1, L2. And you can see the displacement and instability of L1, L2 now in the process of these typical adjacent level disease. And I removed it from laterally and inserted a prosthesis from anterolateral, and in the same manner as has described. And in the CT scan, the position of the prosthesis is well performed. There's another case with an adjacent level disease in L2-3 with a huge protrusio of the disc material and a stenosis of the foramen. And in this case, I put also a prosthesis from anterolateral, but in the CT scan, it seems to be correctly, but in the axial, there was a rotation without any complaints, but it is not perfect. And this is what I want to note. We have to know that the inserter has only these 20 degrees. Perhaps we can improve, or the company could improve the inserter, that we can do it also from the 45 degrees, and to improve also the markers on the rim of the prosthesis, that we can identify the correct AP and lateral position. That's what I want to remark with these some cases, and I thank you very much for your attention again.
Thank you, Professor Rischke. Some question, please.
When you do the lateral approach, you have some asymmetry because you cut the ligament or the annulus on the left side. You don't cut in the right side. And
yes.
As I saw, you don't cut in the front. and you don't release in the back. So you have only one hole, and the picture we have seen, your prosthesis is a little in the front, perhaps not enough at the bottom of the disc.
Yes, the trick
so
is...
your center rotation is to anterior.
You are right. It is not so perfectly done up to now. So therefore, it is, what I said, really tricky. And from my point, it could be improved by myself or by other. It is not reproducible, as I showed here. So therefore, we need some help by the introducers, by the remarks on the prosthesis. And it is not so easy to do. But the first is that if we insert the prosthesis, we have to put it previously first in the lateral and the dorsal rim and the posterior limit, in the posterior line, and then we can position with the inserter in the correct position in the AP and the lateral position. It is not so easy. I agree, and I'm not so happy with my personal results. As only a few. I have performed 5 patients with it, but we can improve it perhaps together, and perhaps with this evaluation of some experimental and anatomical lab in the future.
Any questions? Yes, please.
By that approach, why did you just then mobilize the vessels and take the anterior?
Okay, I wanted to explain that the problem in L5, L1, L2, and also perhaps TH12, L1, is the position, is the anatomy. No? So we have to remove the kidney, and this is a very huge approach. And if we wanted to have a minimal invasive approach, we have to think about modification. No? And that's what I wanted to explain, that it is possible, but it's not so easy. And for materially, from transabdominal, is no option, no? Because we have the artery of the kidney and the vein of the kidney. It is not an option to come from anteriorly to the L1, L2 segment.
I have a question. We deal here with the upper lumbar spine regarding a lateral approach. What do you think about lateral approach for lower levels?
Okay, this is
when you have a choice.
Yeah, I choose it if I perform L4-5, L3-4 in the same area, but from anterolateral. No? This is not so easy, not so difficult as in the upper lumbar spine. The advantage in this, in the lower lumbar spine, is that I can introduce this prosthesis from oblique with 20 degrees, so I can protect the anterior ligament as well as in the upper lumbar spine. I have shown it's the same advantage, but it's not so tricky and difficult as in the upper lumbar spine. Therefore, I wanted to show you the problems in the upper lumbar spine.
Sure.